So just a quick little introduction to endocrinology. So endocrinology is the study of hormones. And something really important to learn and understand with this is the hypothalamic pituitary axis. So we have the hypothalamus, which secretes releasing hormones, which triggers our anterior pituitary gland to release stimulating hormones. And these go out to target glands to release the end hormones, which are like cortisol, thyroid hormone, estrogen, testosterone. And these work on a negative and positive feedback mechanism. So as the end hormones increase, we get a decrease in the stimulating hormones and a decrease in the releasing hormones. If these are low, the opposite happens. So firstly, we're going to talk about dyslipidemias. So let's talk about lipid transport mechanism. So there are two pathways. We have exogenous and endogenous lipid formations. So exogenous, obviously from outside of the body, these are our dietary lipids. And we, obviously in the food that we eat, they get metabolized in the small intestine and we form chylomicrons. So chylomicrons are majority triglycerides that we get from our diet, and only 1% protein. And these, the protein, apolipoprotein that's associated with this is B48. So chylomicrons go through our bloodstream and they go out to the tissues and release free fatty acids and the triglycerides. And what we're left with is the chylomicron remnant. And this goes to the liver to get metabolized with the help of the low density lipid receptor. The liver, from metabolizing as it does, it releases very low density lipids, which are here. And they are, again, majority triglycerides, a bit more cholesterol and 5% protein, and the protein associated with it is B100. These go through the similar process as the chylomicrons, so they go out to the tissues, and with the help of lipoprotein lipase, they get broken down into triglycerides and free fatty acids. And then we're left with intermediate density lipids, which are a much higher portion of protein and less cholesterol and triglycerides. Then the low density lipids derive from the intermediate density lipids, and they are 50% cholesterol. So a lot of the triglycerides have been removed, and this is replaced with the cholesterol. And we have a good portion of protein as well, and this is again like VLDL B100 and also like IDL B100. Then we have high density lipoproteins. So this is formed in the peripheral tissues, and what it does, as you can see, it's more than half protein. So there's a lot of space on that molecule to get more cholesterol and triglycerides. So this is why HDL is the good lipid, because it kind of acts like a scavenger. So it goes around and collects all the extra free fatty acids, triglycerides, and cholesterol from the body and takes it back to the liver, so the liver can metabolize it and create more VLDL, and the process continues. Okay, so we have a little MCQ coming up. So what are cholesterols and lipids used for? They are used for energy production, steroid production, bile acid formation, or melanin production, immune regulation, and energy production. Bile acid formation, melanin production, and steroid production, or immune regulation, energy production, and cellular proliferation. So A, B, C, or D. What does everybody think? I think we have a poll we can do. So we only have A, B, C, D. So I think that's launched. I'll give you guys some time. Okay, I think that's, I'm going to end the polling now. I think majority of you voted, and the right answer is A. So yes, it is used for energy production. So we have insulin that will cause lipolysis, which will break down all these fats. And we have energy production, steroid production for our corticoids and cortisol and things like that, and bile acid formation, of course, for bile acid to break down fats in our diet. So, well done, everyone. So then let's talk about, that's a lot of physiology there. So let's talk about dyslipidemia and its etiology and epidemiology. So this is due to lifestyle. So a sedentary lifestyle, a lifestyle with high fat intake in diet, past medical history. So any medications or any conditions that the patient might have that will lead to them taking a certain type of medication. It can be familial and genetic. And as we get older, the prevalence increases. So the older you are, the more likely you are to have dyslipidemia. And 6 in 10 adults have a cholesterol of more than 5 millimoles per liter. And the upper normal limit is 5. So that's a big portion. So what are the reasons that we might have high cholesterol? So we can have a raised cholesterol because we have a lot of LDL in the body. And this is due to polygenic hypercholesterolemia or certain drugs like sertraline. It can be due to LDL can be raised due to less common reasons such as hypothyroidism. So if we think about the thyroid gland as a gland that produces thyroid hormone, which is used for metabolism of things, if we have a lot of it, it speeds up our metabolism. If we don't have enough of it, it slows it down. So if our metabolism is slowing down, we're probably not metabolizing the fats as we would. Then we have things like nephrotic syndrome, cholestasis, familial hypercholesterolemia, which I'll talk about, and anabolic steroids. And we can have raised cholesterol due to triglycerides. And a common reason for that is type 2 diabetes mellitus or obesity, alcohol, pregnancy, and drugs like risperidone. And less common reasons are familial combined hyperlipidemia, again, hypothyroidism, end-stage renal disease, and polygenic hypercholesterolemia. So what are we looking at when we have someone with dyslipidemia? So history is essential to ask. So we need to figure out, is this patient a high-risk individual? And what do we mean by high-risk individual? Somebody who is likely to have a negative impact from this by causing them to have cardiovascular disease. So the history is very essential. So we want to know what kind of person this is. What is their diet like? What is their lifestyle like? Are they getting enough exercise? Do they smoke? Do they drink alcohol? Is there a family history of dyslipidemia? Have they had anybody in their family who has died from ischemic heart disease at the younger than the age of 40 or has been diagnosed with it younger than the age of 40? And any use of antipsychotics, as we said, it was a common reason to cause high cholesterol because of high LDL. So on examination, we want to measure their blood pressure and their BMI. This will help us to assess the risk of cardiovascular disease. There is a Q risk form, and that is calculates the risk of ischemic heart disease in 10 years. And then we want to examine the patient, so we might be able to see xanthomas. These are cholesterol deposits. These can deposit in the eyelids and the tendons and in the palmar creases. Palmar creases specifically would hint to you that it's probably a familial dyslipoproteinemia, and they might have arcus cornelia. So this is this blue haze around the iris. So that is again cholesterol depositions. So this is the Q risk form. So it takes into account gender, ethnicity, smoking status, diabetes status. So it's just a list of potential causes that can increase your risk of having cardiovascular disease. And then this is not necessary, but if it's known, it's better. The blood pressure, the cholesterol to HDL ratio, and the BMI. So this calculates the risk of the person having ischemic heart disease in 10 years. So let's talk about the familial dyslipidemias and hypercholesterolemias. So we have the Fredrickson classification, which is still used. So we have hyperlipoproteinemias, and there are six different types. So the first one is hyperchylomicronemia. So the way I would remember this, so type 1, the first one that we spoke about, chylomicrons, straight from the gut, straight away. So type 1 is stage 1, hyperchylomicronemia. So this has increased chylomicrons. And as we saw in our diagram earlier, that it had a high content of triglycerides. So the fat fraction that is increased, the lipid fraction that is increased is triglycerides. Then we have type 2A, which is familial hypercholesterolemia, and this is raised LDL, and like we saw on the diagram, that it had a high portion of cholesterol. So the cholesterol is a fraction that is raised in this case. So, and then we have, so I would remember that one 2A, and it has 2 words in it. So familial hypercholesterolemia, so type 2A, 2 words, and it's LDL, and then the cholesterol that is raised. Type 2B, which is the third one, and it has 3 words, so familial combined hypercholesterolemia. And this is a combined, so it's raised LDL and VLDL. So in these, the cholesterol and triglycerides are raised. And then type 3 is a dys-beta lipoproteinemia, and this is raised intermediate density lipoproteins, and this again increases triglycerides and cholesterol. And then we have type 4, which is familial hypertriglyceridemia, which is in the name, raised triglycerides, and it's VLDL, that's the lipoprotein that's increased. And type 5, which is the most different one, so it's the last one, it's completely different. It's familial lipoprotein lipase deficiency. So as you might remember, I mentioned that lipoprotein lipase breaks down the lipoproteins to allow the release of free fatty acids and triglycerides into the tissues. So if we don't have this, we have an increase in triglycerides and cholesterols because VLDL and chylomicrons are increased. So these were the two that were broken down by lipoprotein lipase. If we don't have the enzyme that's going to break it down, these are going to increase, and this leads to an increase in triglycerides and cholesterol. I hope that makes sense to everyone. I feel like that was just a lot of information. Okay, so how are we going to investigate this? So we can measure the patient's total cholesterol, and this will be more than 7.5, and it should be, like I said earlier, the upper normal limit is 5. And if this is the case, we have to do a fasting lipid profile. We can measure triglycerides, which would be more than 4.5. And again, if this is the case, we have to do fasting lipid profile. So these will be taken randomly at an appointment, and then we would ask them to do fasting to see what their body, how high their cholesterol or triglycerides are in a fasting state. And they shouldn't be very high in a fasting state. So, and also we'd want to do a thyroid function test to see if hypothyroidism is a cause, for which that would need treatment with levothyroxine. So why would hypothyroidism cause it? Elevates LDL and triglycerides, again, because there's not much breakdown occurring. We have renal function, specifically to check if the patient has advanced chronic kidney disease. This would impact dyslipidemia because it causes, when a person has chronic kidney disease, it causes downregulation of lipoprotein lipase and a decrease in HDL as well. So our good lipoprotein isn't around to scavenge all the fat that's there. We also want to do liver function test, as a raised ALT may indicate to ectopic hepatic fat in obesity, which leads to elevated triglycerides. And we want to check glycated hemoglobin. So if we have elevated triglycerides, this might be a marker of insulin resistance. So again, insulin causes lipolysis. If this is the case, we want to check for type 2 diabetes as well. If that's the case, we might have low HDL. So again, high triglycerides, no HDL. And we've got an increase in triglycerides and no HDL to scavenge it. So the management. So we want to be able to treat the rectifiable causes before starting on medication. So we want to, again, make sure that there's no medication that they're on that might cause this. If there is, see if we can find an alternative. if it's due to their lifestyle, then we can, give them a health program to get them eating healthier, doing more exercise, lifestyle changes in current medication. However, high-risk individual from the Q-risk score that we spoke about earlier, they will require statins. If we are to start a patient on statins, this is a chunk that I took out from an article. You want to check ALT at the baseline, and you want to check 3 months and 10 months, and 12 months, sorry. And we also want to check creatinine kinase if there are muscle symptoms present. So this is because statins can have an increased risk of rhabdomyolysis. So this is breakdown of the muscles, and this increases creatinine kinase, and we can get this found in the urine as well. So we have to stop statins if the person is pregnant or breastfeeding, and we have to arrange annual review to offer more lifestyle choices and modification. So this is the link to where I got that information from. I think it's a really good article to go and read, and it's a good pathway to follow. So that was all I have on dyslipidemias. Are there any questions so far? Okay, sorry, I've gone. LDL is formed in the liver. Was a question, and yes, you are right. Bile acids break down, emulsifies the fatty food, basically. So let's speak about metabolic syndrome. Metabolic syndrome. So this is an accumulation of several disorders that lead to an increased risk of developing cardiovascular disease, insulin resistance, diabetes, mellitus, and cardiovascular accidents. Any three of the following. So out of this list of 5, if a patient has any 3, that is a diagnosis for metabolic syndrome. So a waist circumference of more than 40 inches for men and more than 35 inches for females. Elevated triglycerides, reduced HDLs, elevated fasting glucose of more than 7, and elevated blood pressure. Someone's just asked a question, is there a link between stress and high cholesterol levels? I'm not too sure about the answer to that, to be honest. I'll have to have a look. I'll look it up and get back to you about that one. Yeah, I will go back to the 3. Sorry if I went through that a bit quickly. So any of the 3. So waist circumference. So we're looking at waist circumference. I don't know why I need to elaborate on that one. Elevated triglycerides, reduced HDL, elevated fasting glucose of more than 7, and elevated blood pressure. So waist circumference, I wanted to elaborate because that is basically central obesity is what we're looking at. So more than 40 inches for men, 35 inches for women, elevated triglycerides, so high triglycerides, reduced HDL, so no scavengers, elevated fasting glucose, so maybe some insulin resistance or diabetes going on, and elevated blood pressure. So any 3 out of those 5. So underlying etiology, so the patient may be overweight, have a sedentary lifestyle, and a genetic predisposition to metabolic syndrome. So let's talk about pathophysiology. So one of the biggest things was obesity. So we have a buildup of adipose tissue, and having high adipose tissue leads to insulin resistance. So pro-inflammatory cytokines are released from adipose tissue, which also impact insulin handling. Visceral fat has a stronger distribution to insulin resistance than subcutaneous fat, so again, the more central obesity. And insulin resistance leads to microvascular damage, so endothelial dysfunction occurs, hypertension occurs because of this vessel wall damage occurs, and this then goes on to impact other organs, end organs. So the key that you can see there is having a high adipose tissue, and this leading to insulin resistance. So the high adipose tissue, as well as the triglycerides that are there, we have the endothelial damage, cholesterol and triglycerides are high in the blood. This is going to increase risk of atherosclerosis. So it all just kind of links together, with the central thing being obesity, having a sedentary lifestyle, although there is a genetic cause to it as well. So important is history and physical examination. So again, we want to find out about their person, a little similar to dyslipidemias, find out about their background, what their lifestyle is like. We want to examine them. Again, waist circumference is one of the points in diagnosis. Acanthosis nigricans, this is a really good indicator by just looking at a patient without doing investigations of insulin resistance. So this is darkening of the skin around the back of the neck, around the underarms as well. That's one thing to look at. And we have elevated blood pressure as well, which was another point in the diagnosis. And again, for our evaluation, we want the lipid profile to look at the raised triglycerides and the decreased HDL. We want to see HbA1c as well to see if there is some kind of prolonged diabetes going on. We want to check the levels of glucose. We want a renal profile, liver function test, thyroid function test, and uric acid, and an ECG as well, just to check the heart, because there might be some evidence on the ECG of previous ischemic injuries. So how can we treat this? So this is a syndrome with many different factors at play here. So we want to be able to treat the modifiable factors. So we want to, again, promote a healthy lifestyle, better diet, more exercise, treat the underlying causes as well, treat the diabetes if there is occurring, treat the hypertension. The main key here is weight loss as well. So if, they're beyond a point where they can't lose the weight, then we might be able to do some kind of bariatric surgery, but this is usually only for a very, very high BMI and if they have comorbidities as well. Any questions on metabolic syndrome? Okay, let's move on to diabetes mellitus. Okay, so diabetes mellitus. So let's talk about glucose control first. So if we have a high blood sugar, our body should release insulin. What should be released if we have a low blood sugar? So you can type into the chat what hormones should be released if we have a low blood sugar. Glucagon, yes. Catecholamines, yes. So that's 2. So when we have high blood sugar, we release 1, insulin. Cortisol, yes. Very good. So I'll give you a hint. There are 5 that are released. So we've got cortisol, glucagon, and catecholamines. There are 2 more. Yeah, growth factor, GF, do you mean growth factor? Yes, yeah, growth hormone, yes, fantastic. Okay. Ghrelin, I think that is more for satiety and hunger. So let's get it out there. Sorry, those 4. You got them all. Moving on. Well done, everyone. You got them absolutely right. So if we have hyperglycemia, glucose is an osmotic. So it's going to draw fluids into the bloodstream. So this is going to cause polyuria, polydipsia, and increased thirst. So how many types of it's poll time. How many types of diabetes do we think there are? There are 2, there are 3, there are 4 types, or there are more types? So I don't know why E is an option. I don't know how to get rid of it. I do apologize. But what do we all think? How many types of diabetes are there? No, DI doesn't count as one. So I was speaking about diabetes mellitus. Okay, I'll stop the polling now. So, yeah, majority said more, and that is right. There are more types, and we'll speak about them. But just about diabetes mellitus. So diabetes means to pass through. So this talks about the symptoms of polyuria and polydipsia and increased thirst. So we're drinking more and more and more, and we're just peeing it out. And mellitus means sweet. So when doctors didn't have blood tests and things back in the day, they would taste the urine, it would taste sweet, and that would give them their diagnosis of diabetes mellitus. So let's speak about the different types. Now, I don't have them all on here. The one that is missing is LADA, and there are other different types as well, which are just monogenic mutations which lead to diabetes. But LADA is latent autoimmune diabetes of adulthood. But we'll speak about type 1 and type 2 primarily. I'll just say a couple of words on these two, and I know we're quite short on time. So type 1 diabetes mellitus is autoimmune destruction of islet cells, either by islet anti-islet cell antibodies or anti-GAD antibodies. So this is an insulin-dependent type of diabetes mellitus. And this is usually diabetes that occurs in children and is usually diagnosed following an episode of DKA, unfortunately. And another emergency is once we're treating is hypoglycemia. So DK is diabetic ketoacidosis, and I will speak about a little bit about that in a little while. We then have type 2 diabetes mellitus, which is caused by insulin resistance, as we spoke about earlier, and this is due to genetics and lifestyle. So this is a non-insulin dependent type, so this can be treated with lifestyle changes and medications. And the emergency in this would be hyperglycemic hyperosmolar state. And again, once we're treating, another emergency would be hypoglycemia. We have MODY, which is maturity onset diabetes of the young. And this is an autosomal dominant inherited condition, which is not autoimmune. It's actually a genetic mutation in HNF1A and GCK, which are the intracellular signaling pathway, parts of the intracellular signaling pathway for glucose intake into the cells. So there's enough insulin on board, there's receptors on board, but there's just no downstream pass of that message along. So this is a non-insulin type of dependent diabetes as well. And again, similar to type 2, we have HHS and a hypoglycemia. And gestational diabetes is affected by the hormones that are released during pregnancy, and they affect beta cell function and cause some insulin resistance. Okay, so how are we diagnosing this? So patient will come in with a history of polydipsia and polyuria. Unfortunately, in children, they usually present in DKA. Again, I'll speak about that shortly. So we want to check a random venous glucose, and if it's more than 11 is a point towards diagnosis. We want to then check a fasting plasma glucose, and it's important to do both because sometimes you can do a random venous glucose. If the patient has just had a meal, it's obviously going to be quite high. So it's not a true representation. That's why we do a fasting plasma glucose. And we may want to do an oral glucose tolerance test as well. So if in that case, after doing an oral glucose tolerance test, it's more than 7, that's impaired glucose tolerance. But if put 2 hours post the intake of the glucose is more than 11, that is our diagnosis confirmed. So another poll. So what is the normal range for blood glucose? A, B, C, or D? 5.5 to 7, 3.5 to 7, 7 to 11, or 3.5 to 5.5? Okay, it is actually 3.5 to 5.5. Okay, well done. So I will speak about diabetic ketoacidosis really quickly. So insulin is needed in the body, obviously. It acts like a key for glucose to get into the cells. So if we don't have insulin, glucose isn't getting to our cells aren't getting the energy. So then they have to find an alternate form of energy. So this will be through breaking down of our fats to create ketones. Ketones are then used as an energy source. If we have very high ketones, this lowers our blood pH, causing acidosis. So we have diabetes due to the high blood sugar. The sugar's in the blood, but it's not getting in the cells. The cells don't have energy, so they produce ketones. Ketones lower the blood pH, so we end up with acidosis. So a patient in acidosis will come in with vomiting, abdominal pain, decreased consciousness, and Kussmaul breathing. So the Kussmaul breathing is a compensatory mechanism to get rid of carbon dioxide from the body, as this then goes down to become acidic, and which is just a quick way to compensate for metabolic acidosis by really rapidly breathing to get out all of the CO2 that we can. So patient comes in, is in this state. Parents might even say that they've been, it's usually going to be someone quite young. They'll come in with this vomiting and abdominal pain, and parents might say that they've had some loss of weight, they've been drinking loads, peeing loads. Someone who is potty trained is now, as in could sleep through the night without going to the toilet, now has to get up quite often to go to the toilet as well, at which point you'd want to do a blood gas. We want to check their pH, which would be less than 7.35. They'd have a high blood glucose. And we'd also then would want to check their ketones, which would be more than 1. We'd also do a urine dip as well to check for glucose and ketones in the urine. So once we have our pH and we have our high blood glucose and ketones, we've got our diagnosis for diabetic ketoacidosis. So we need to manage it at that point. So we want to get them fluids, because they will have a lot of vomiting and, of course, dehydration. So we want to get them fluids. We want to get them an insulin infusion to start them giving them insulin that they don't have, to get all the glucose that they can back into the cells of the body. So once we're going to remove the glucose from the bloodstream into the cells of the body, we've not got our osmotic factor anymore. So our symptoms, you'll see the patient have decrease in urine output, which shows us that our management is working. Well, obviously the glucose going into the cells will reduce the blood glucose levels, and we'll also have a decrease in ketones as well. So we can tell how dehydrated the patient is by looking at their pH, and we correct for that deficit over a 48-hour period, give them insulin, keep them nil by mouth, and then once they have a reduction in ketones, we can get them eating again. If they can tolerate foods, we start them on the insulin. So that's how we kind of usually end up getting to our diagnosis of type 1 diabetes. Sometimes it gets caught earlier and they come in through a GP referral, but usually this is what happens. So once they are diagnosed with it, they have to manage their type 1, and it's a really life-changing condition to have to manage, because you can't go a meal without taking your insulin. So we treat this with multiple daily injections. So even in a fasting state, there's some kind of insulin in the background. So we give them what we call a long-acting insulin, to give them once a day, or this can be broken up twice a day to give them a base rate of insulin throughout the day to keep their blood sugars low. And then before every meal, they take a short-acting insulin, which lasts about 4 hours and peaks at 2 hours. And this just keeps their blood sugars nice and normal throughout, even when they're having a meal, and it gets their cells using the glucose that's in the bloodstream. So that's all about DKA and type 1. So type 2 can be treated with lifestyle changes. If we can't help with lifestyle changes, we have to give them medications. So we can give them metformin, which is the most commonly used medication for type 2. And it's a biguanide, and that controls blood glucose levels. We can also then, if there's not much control with the metformin, include another medication. So we can include DPP-4 inhibitors, which break down, which is an inhibitor to break down incretins. Incretins increase insulin secretion, so we don't want to break them down. We want more incretin, we want more insulin. So we can treat them with DPP-4 inhibitors. And we've got sulfonylureas as well. There's again, NICE guidelines are amazing with this. I haven't dealt much with type 2 diabetes, as it isn't very common in children, so this is worth looking at through the NICE guidelines. So what are the long-term complications of having diabetes? So having high blood sugar causes damage to our endothelium. It causes glycation of proteins and leads to end organ damage. So we get diabetic neuropathy. So you might have seen this with patients who have loss of sensation in the lower extremities. This is due to the neuropathy. We have diabetic nephropathy, which can lead to something like nephrotic syndrome. We get hypertension, and we get increased risk of cardiovascular damage as well. Having the diabetic neuropathy and the poor circulation as well, they can have very robust infections of the foot, also known as diabetic foot. So every person who comes in with diabetes, they always get a foot check. So let's talk about diabetes insipidus. So diabetes insipidus, so similar to diabetes mellitus, diabetes means to pass through. So there's a similarity there as the symptoms of polyuria, polydipsia, nocturia. And insipidus actually means not tasty. So again, this goes back to doctors not having tests back in the day and would diagnose things by tasting fee. So a person who comes in with increased thirst, increased urination, they don't know it's mellitus, it's insipidus, let's taste it and name it accordingly. So what is diabetes insipidus? It is a symptoms of polydipsia and polyuria due to decreased response to antidiuretic hormone. So to diurese obviously means to pass urine. If we have a hormone that's called antidiuretic hormone, it is going to stop us from diuresing. If we don't have antidiuretic hormone, we're going to be diuresing a lot. So this can be central type or nephrogenic. It can also be adipsic or dipsic. So this means, do they have an intact thirst mechanism or not? So this is important because just as a side note, we had a case quite recently that there was a child who had a craniopharyngioma, which was removed. Parts of the hypothalamus were damaged, so she has no metabolic function, no pituitary function, so she has no metabolism whatsoever. One of her biggest problems at the moment is her diabetes insipidus. So she is always diuresing, but because there was such damage to the hypothalamus, she does not have an intact thirst mechanism. So she will continue to diurese, but she doesn't get thirsty. So she has to be forced to drink water, which is quite quite interesting actually, and quite sad to think about that every aspect of every intake that she has, food and drink, has to be monitored and controlled, and she gets everything is by the number. So passing a lot of urine can lead to electrolyte imbalance as well. So the causes are central, so it can be idiopathic. There might be a defect in synthesis, and there might be deficiency of ADH, so it might not be made properly, or there might not be enough of it, and it can be congenital, again due to hypothalamic malformations. We can have the acquired type as well. It can be autoimmune, so autoimmune damage, vascular disease, sarcoidosis, craniopharyngioma, like I mentioned, Langerhans cell histiocytosis, surgery, again, like the craniopharyngioma case, trauma, structural malformation, metastasis, hypoxic brain injury, or ischemia. So quite a lot. So the nephrogenic type. So this is a gene mutation in the AVPR2 or aquaporin 2 gene. So there is no aquaporin receptors, or the receptors are defective. And these receptors are found in the collecting duct of the nephron, and all they allow through, it's called aquaporin. So it's a pore that just lets through water. So we are only losing water in this case, no electrolytes. So it's diluting our urine. So it can be congenital, or it can be due to drugs, for example, lithium, antibiotics, some antifungals, and some antineoplastics. Other causes can be renal disease, sickle cell disease, obstructive uropathy, pregnancy, and other electrolyte disturbances. So signs and symptoms, they will come in with polyuria, polydipsia, and nocturia, and having a good history is key to figure out exactly what is going on. Do they have any other symptoms that could affect that could point to any of the things on the list? Are they taking any medications that could be on the list of causes? So, sorry, 1 second. Nocturia is when you need to get up in the night to pee. Sorry, there's another question that I missed. Can you explain what happens to the water when there's high sugar again? So sugar acts is osmotic. So having high sugar increases water and causes water to go into the bloodstream. Well, not go into the bloodstream, but increases intravascular volume, because it will cause it's not water to go into the body, it'll just increase intravascular volume. Having a more intravascular volume will cause the kidneys to increase their function and cause more urine output. If we have more urine output, we'll have increased thirst. So diagnosing DI, so we would do something called the water deprivation test. But before we do this, we would want to check for other hormone levels, pituitary hormone levels as well, to see if there is more than one hormone deficiency, as there are more dangerous hormone deficiencies to have. For example, if we have low ACTH, we won't be producing cortisol. If we fall ill and we need a stress response, it won't be there. So we need to make sure that there are no other hormone deficiencies. DI, we would diagnose using water deprivation test. Also, checking for other hormone deficiencies would also guide us towards our diagnosis, or our cause for the diagnosis of DI. So, sorry, let's talk about water deprivation test. So we deprive the patient of water for 7 to 8 hours, and then after this, we give them DDAVP. So if we're not going to give someone water for 7 to 8 hours, they're going to, their urine that was very dilute with water will start to become more concentrated. So what we do throughout the test is that each hour we measure urine osmolality, plasma osmolality, and if it's just primary polydipsia, where they're just drinking lots and lots, and because they're just drinking lots and lots, they're having urine output. We will see that the urine will slowly become increased concentration, so the osmolality will increase, whereas we'll see the opposite of plasma. However, if they do have DI and we're depriving them of water, the urine osmolality should not change. It will still remain quite dilute. So then we have our diagnosis. So this is definitely DI. We've deprived them of water. They're still passing really dilute urine. So then we give them the DDAVP. So is it just a deficiency that they have, or is it that the receptors in the kidneys are not working? So we give them the DDAVP, which is also known as ADH. We give that to them. If they then start to concentrate their urine, because it's antidiuretic hormone, it's going to stop all that water going into the urine, we will then see a decrease in the urine output and an increase in the concentration. However, if it's nephrogenic and it's the receptors that are the problem, there shouldn't be a change still. So this is another pathway that shows us how we get to our diagnosis of DI, and specifically which type of DI. I was going to go into it, but I feel like I'm very short on time. So really just look at this, work through it when you have some time of your own, when you get the slides. And just, yeah, it's very good. It makes complete sense. Just for reference, when you go back to it, plasma copeptin is basically something very similar to ADH. It works very similar to it. So it's another measure. So management. So if it's central, again, we give them DDAVP. We give them a low solute diet, so we restrict sodium. We give them some diuretics, thiazide, which will increase the electrolytes that are lost, so it's not going to be so dilute, and there won't be such an electrolyte imbalance in the body then. By electrolyte imbalance, what I mean is that we'll have more raised electrolytes. We'll have a very, very high sodium because we've lost so much water. And we can treat with NSAIDs and carbamazepine, but so far where I've been working, I've only ever seen it being treated with DDAVP. If it's nephrogenic, we want to treat the underlying cause. If there is any renal damage, discontinue the medication that might be causing it. We can use a thiazide diuretic. If there is some renal function from the receptors, we could give them DDAVP or NSAIDs as well. So I'll quickly speak about acromegaly, but does anyone have any questions on diabetes insipidus? Lovely. Oh, there is one. How does the thiazide work? So what it works on is a different part of the nephron. So it triggers aldosterone, and this causes sodium and water retention. So there'll be less fluid going into the collecting duct. So it's again causing retention of the sodium and the water by triggering the aldosterone. Which does, yes, I agree with your point, but I think a side impact of the thiazide is triggering the aldosterone. So it will have its diuretic effect as well, but it will cause the triggering of aldosterone to cause water retention. So acromegaly. So acromegaly is excessive growth hormone production. This is most commonly due to an adenoma of a pituitary gland. So this is a picture of a woman who has acromegaly, and that's taken over about 10 to 11 years. And you can see the changes in her face that have occurred. So her nose has gotten bigger, her lips have gotten bigger, the bridges around her eyebrows have gotten bigger. So everything is huge because it's increase in growth hormone. So what causes acromegaly? So we have an excess of growth hormone. This can be due to functional tumors. So we can have a pituitary adenoma, craniopharyngioma, or meningiomas, pituitary hyperplasia. So this can be caused if there's a problem with the hypothalamus and there's no releasing hormones. The pituitary will go into hyperplasia to stop producing hormones. We have malignant tumors, germ cell tumors, metastatic tumors from the lung and breast also release growth hormone. And excess growth hormone increases insulin like growth factor 1. So if there is increased growth hormone release before growth plates have fused, so from childhood, this will affect the long bones and this will lead to gigantism. If this happens after the growth plates fuse, we have excess mineralization of short and cranial bones. So we'll have enlarged hands, feet, skull, and a prominent mandible. And there will also be enlargement of internal organs as well. Clinical manifestations, so there'll be insulin resistance. So we'll have hyperglycemia. There'll be hypertension and cardiomegaly, acroparesthesia, which is tingling in the fingers and toes. There may be amenorrhea, increased sweating, macroglossia, which is a big tongue, obstructive sleep apnea, again due to overgrown tissues, and arthralgia, pain in the joints. Investigation, so we want to check serum IGF-1. If this is raised, this points towards our diagnosis. And then we can check the growth hormone suppression with an oral glucose tolerance test. So like we mentioned earlier, if we give them glucose and there's raised blood sugar, there should be a suppression in the growth hormone because we don't need any glucose production, so growth hormone should be suppressed. If growth hormone isn't suppressed when we give them glucose, then this points towards our diagnosis. We want to study other pituitary hormones as well. And we want an imaging of the head. Imaging we'd want to do in DI as well to look at the pituitary stalk. So acromegaly is managed by a dopamine analog called bromocriptine, a somatostatin analog called octreotide, pegvisomab, which is a growth hormone receptor antagonist. And if there's a mass, we can have surgical removal of the mass as well.